Good afternoon, everyone, and thank you so much for having me. I'm truly honored to present alongside such a wonderful group of professionals across many disciplines. I'd like to also acknowledge the team that I get to work on every day, who's made it possible to present on such an amazing program we have here at AHS EMS. So I will jump right into the meat and potatoes of it. So what I want to talk to you guys a little bit about today is a program that we've called a reintegration program. And if you can keep in the back of your mind, while this is EMS specific and EMS centric, I do want you guys to think about it in a capacity where, how could I use a program like this in my workplace or in my occupation or in my patients' or clients' occupations. So keep that kind of at the forefront of your mind as we're going through this. But what I want to do is give you a little bit of background and understanding on our specific program and how that can kind of carry on into other occupations. And while most of the work we do is surrounding psychological injuries, we do work with staff and paramedics that have both physical and psychological injuries that they've experienced. And so I'll talk a little bit about how that integrates as well. So a little bit of background on our program. So it really has its roots in policing, and where we started to build our program, we actually started to learn kind of from the Edmonton Police Service and what they were doing. And so we work really closely with them. So we were able to kind of pass ideas back and forth. So we kind of took a little bit of their program and turned it into what we have today. So our reintegration program is here to support staff in a return to work type of manner. And the emphasis is really placed on that psychological safety and in a really healthy manner specific to the individual. So each plan, similar to a return to work plan, would be very individualized and built specific to each member that we're working with. And so in the beginning of our program, it really was kind of an undercover covert operations because there was a lot of that mental health stigma that came with, oh my gosh, okay, this person's off due to a mental health injury. Why are they back? Why are they not back? What are they doing? So we started really undercover, and now today, over the past 6-7 years, we've actually grown into a program that we want to be front and center. We want people to know what we're doing, and really now we're trying to actually kind of promote it to external agencies, which luckily I'm here to talk to you guys about that today. So if there are questions later, I welcome any and all questions. So like I said, we've been supporting staff since about 2015 is when we first started the reintegration program. So I'm going to talk to you guys a little bit about the who, what, where, when, why. Sometimes when I give this presentation, it's an hour and a half long. So I'll try to give you some meat and potatoes to what our program looks like. So who does the reintegration program support? And so I really want to make it clear that we can support any and all folks within our emergency medical services department, but this kind of platform can really help any and all occupations. So for us, we can support our emergency communications officers. We have multiple frontline paramedics that we would support. So whether you're in a ground ambulance or an air ambulance, whatever your vehicle would be, as well as our out of scope staff. So our managers, supervisors, even up to a director level. So we really take a holistic approach to supporting all of our staff so that they know, if they are off due to psychological or physical injury, that they're going to have support in their specific area. So in speaking to who helps with this and who kind of helps run our program, those are our trained facilitators. And I won't go into all the training that they get, but I was really intrigued by Dr. Jackie Gardner's discussion where she talks about mindfulness, because that's a huge piece to what we do as facilitators and what we do in the program. And we actually promote mindfulness and that mind-body connection when we're going through reintegration. We actually get our members to practice some of those techniques. So just a throwback to Dr. Jackie's talk about mindfulness. So our facilitators have that kind of training, along with other pieces. We work with psychologists and occupational therapists to give us specific targeted training on prolonged exposure. But we have our facilitator group that actually will provide these sessions, and we actually take direction from a varied list of treatment providers. So, I mean, we've worked with members that have occupational therapists, psychologists, psychiatrists, maybe they also have physiotherapists involved. So the treatment team could consist of, upwards of 5 or 6 different treatment providers that we're engaging to take directions on how our sessions are going to look. So our facilitators have supported sessions for over 250 staff over 6 years, and we're growing. And to be honest, since I've kind of started in this job, it's taken off, and we are rapidly exceeding what our capacity is right now because we are so busy, which is great. We like to hear that. We want to be busy supporting our staff. So we also are currently assisting other agencies right now in supporting their members and helping different agencies build their programs. So for example, we just worked with St. Albert Fire and Emergency Services here in Alberta. We worked with them to help them build their specific reintegration program, and we brought their facilitators along with us to teach them how we do it, and then they can kind of go back into their own programs and build it how they see fit with their nuances in their areas. So we're really passionate, our team's really passionate about teaching other folks who want to build their own program, how they can do that, and kind of give them some insight into what we're doing. And nothing's a secret. We don't need to recreate the wheel. So any information that we have, we are always willing to share that. So the what? So what is a reintegration session? So our sessions look different for every individual person coming through the program. So whether it's for our emergency communications officers, paramedics, or a leader, and it's mostly based on a fear hierarchy that we get from the treatment provider and the treatment teams. And so those fear hierarchies can include a multitude of things. So some, common ones that we might see include fears to putting on a uniform again. So some of our members might have been off for, upwards of a year. So putting that uniform on, how does that feel? And, is there psychological pain that comes along with that, or what are the feelings that come along with that? Other things such as stations. So depending on where their stop-start station is, where they get their ambulance in the morning, there might be some fear surrounding going back into that area. Locations of calls are big ones. So especially when there's things in public places, so maybe malls, or, depending where those calls really happen, those traumatic calls happen. Pieces of equipment. So something as simple as, an IV catheter, all the way up to working with ET tubes or a laryngoscope. There might be specific pieces of equipment that are causing those triggers. And then types of calls or our patient presentations or demographics. So, maybe it was a traumatic pediatric call that you went to. So maybe pediatric calls are something that we would like to focus our exposures on. And then speaking about having a psychologically safe and healthy workplace, sometimes there's fears to having peer interactions. So what's your interactions with your supervisors, with your partner, with patients? All those come into play when we're building these reintegration sessions and what that plan could look like. So we currently don't really have a set amount of sessions. So we don't have a minimum or a maximum. We work within the parameters and how the treatment teams are helping support the member. And we kind of will base that off of that fear hierarchy. So, maybe we need 10 sessions to cover the different fears off of there. So right now we don't have any set amount of sessions that we would cover. So where do we do this? And I want to emphasize that we do support an entire province. So absolutely, geography can be a challenge to us. So we go, as north as Rainbow Lake and as south Crow's Nest Pass, that kind of thing. We have facilitators that are actually located across the province. And so we have a team in kind of each area or zone that we can support members in that specific area. And the great thing is we have a lot of our facilitators have been with the organization for many, many, many years. They've worked across different zones, different positions, and their reputation precedes them. And so we have a really strong reputation across the province of having facilitators that are really, psychologically safe and support that work that we can do. So I'm really proud to say we have facilitators across the province that we get to work with. So when do we look at kind of bringing in the reintegration program to help assist members? So generally how we would get brought into kind of the treatment plan of the member is we come in before, ideally, we come in before return to work has been planned. Sometimes when people don't know about us or don't know our program, or, they're unfamiliar, sometimes the return to work might start. If it's unsuccessful, then there might be, a manager that says in operations that says, hey, reintegration, this return to work plan isn't going as well as we'd like it to. Can you touch base with the member to support? So we can also come in the middle of a return to work, but ideally we'd like to be brought in before that member is cleared for a full return to work. So our team generally is contacted when the treatment provider or providers, the member or other stakeholders like WCB, workers' compensation, or the abilities management team for your organization, for the organization. And so generally they'll send our team, and we have a provincial email that we would receive these requests. And then from there, we would actually liaise with all of those stakeholders that are involved. So the treatment provider, the member, we'll say WCB, for example, as well as someone who's representing the organization. So like a manager of that member, just so that everyone can kind of be on the same page. And we actually, because all of our facilitators were all advanced care paramedics and we're all working within the confines of our licensure and our body, regulatory body, we actually can't carry out any kind of reintegration session or exposure, prolonged exposure session until we have the go ahead and okay from the overseeing treatment team. So for example, the member could come to us, hey, Rhea, I've been off for 6 months. I had a really crappy call. I've been doing my therapy and with my treatment providers. Can I come back and do some reintegration before my return to work? I'll say, absolutely, yes. Can we talk to your treatment provider? I can give them an outline of what we can provide here in reintegration. And then once we get the okay from the treatment provider, we'd kind of carry on in that process. So a lot of times, and what we're currently seeing more often now is integrating this reintegration program as part of a TPI program or a traumatic psychological injury program. So, and according to WCB in the province of Alberta, and again, we've worked really closely with them, they have actually approved sessions with our facilitators as part of treatment. So we are actually considered part of the treatment team, and we liaise with the treatment teams who are carrying out that TPI program. And we'll bring that real life perspective and the real tangible pieces of being a paramedic. We actually can bring that component to that TPI program. So for example, a member might be working with their occupational therapist or their psychologist, CBT, and they're in that clinical kind of room setting. It's not the same as when you're back sitting in an ambulance with those lights and sirens going, or as you're driving. And so once the member has done that groundwork in the clinic setting with the psychologist and the OT, that's when they'll connect with us to bring in those pieces of equipment, doing the lights and sirens, driving. If we're running simulations or doing specific types of calls, we have high fidelity mannequins that we can bring in and help them practice their skills, help them gather that confidence back while being mindful and working through all those pieces that they're doing in their TPI programs. So we're really putting it into practice in the workplace, what they're learning in those TPI programs. And again, this is a member-driven program. And I do want to say, I don't think I've said it yet, we're actually an optional program. So folks coming back to us who are off with psychological or physical injury, they do not need to come through our program. It's all voluntary and kind of driven by themselves. And it's really interesting talking to members. They often tell me, Rhea, this is like the first time we've ever been consulted in our own, plan and program going forward. And they're almost shocked and kind of in awe that they're being asked, what do you want it to look like? How can we support you? What are your decisions on this? So we really put the emphasis on that it is member driven, because that's what creates a more successful reintegration and then hopefully a return to work program later. So why do we do this? And this is, I think, a really, really important slide. And again, I said we brought it in 2015, and it really came into play because we had a member who died by suicide as a paramedic, and the partner was the first person that kind of came through reintegration, and that's who we were first trying to support. And what we really wanted was to just give that member everything that they needed to feel safe to be able to come back to work, because that's what that member wanted. The member wanted to come back to work. So as the organization and employer, we're like, how can we make that happen? So really, we are here to help members navigate that return to work process, because we all know in those processes, there could be, upwards of 5, 6, 7 people that are involved or that need to be involved in that return to work process. And that can be pretty overwhelming at times. So we like to say we're that neutral party. We're not the employer pulling you back to work. We're not WCB pushing you back to work. We're a peer, and we're actually standing beside you, walking with you on whatever goal line you're trying to make it to. And that's what we're here for. And so we really do a lot of work surrounding that prolonged exposure therapy. And we work really closely with our occupational therapists and psychologists that we often work with and share members with. That's how we're helping to support that sustainable return to work. We also give pieces to the treatment providers so that they can better understand the internal organization processes. And with those lines of communication being opened, we've found from all parties that it's really been beneficial to kind of just have, the reintegration program coordinate that reintegration and return to work. So we're helping support those treatment teams provide more targeted treatment. Like I mentioned, we are able to bring the treatment that they're doing in the clinical setting, we're able to bring it into real life. We're able to go on calls. We're able to slowly help build that confidence back up as they're on their path to return to work. And so we've spoke to our members, we've spoke to treatment teams, we've spoke to WCB, our disability management, as well as the employer, so the supervisor manager teams. And anecdotally, really, really great reviews. And I would like to think that our reputation is kind of speaking for itself in the sense that we've grown and our numbers and our requests for reintegration have grown so fast that we're having trouble actually following that growth. So we're also actually involved right now in a study that's being conducted to understand the efficacy of the program. So there's actually going to be some qualitative and quantitative data coming out of this study. So any of the members at AHS EMS, as they've come through our program, they're actually being kind of passed on to this study to see if they'd like to participate and give their feedback on the reintegration program. So far it is anecdotal, but we're hoping in the future that there's going to be some good qualitative and quantitative data coming from that. So how can this kind of session and program happen? So what can it look like? So initially, when we are connected to the member or a request comes in, what I will do, I will look at our list of facilitators and say, okay, Jimmy has availability to take another member. So what I'm going to do is I'll connect with our facilitator and give the contact info. Of course, the consent has been given at this point, but I'll give him the info and he's going to go ahead and connect with that EMS member. And so what they're going to do is actually have a meet and greet. Usually it's a coffee outside of the workplace, outside of work hours in their favorite coffee shop, just to build that rapport. And then they're going to review that hierarchy, that fear hierarchy, and go through and plan what sessions could potentially look like. And so from there, sessions, they can range anywhere from, 1 to 2 hours up to potentially those 8 hours when we're at the end of reintegration, looking for calls, going on calls, because those can take a bit longer. But then we're actually going to go ahead and the facilitator is going to carry out those sessions. And we're always in discussions with the treatment team. So anytime we do a session, we would send those session notes on to the treatment providers, so they're kept in the loop. The member is always included in all of our email communications, so there's transparency there. And then once we've made it to those final return to work pieces, that's actually when we sit down and build a return to work schedule with the member. And we have found that when the member has input into what their return to work looks like, it's so much more successful. And so that's usually our last session. We'll build that. And, after all the parties agree, then we would go ahead and schedule that return to work. And throughout, our facilitators are going to be doing those check-ins to make sure that if we do need to, change anything in the return to work, lengthen, shorten shifts, do some different things, that we are able to do that. So my final slide here, where do we go from here? And so in our department, we're continuing with that research. We really want to get that qualitative and quantitative data to kind of reinforce what our program is doing. And actually having a reintegration program is now being implemented into the CSA standard. So we're really excited about that. Continuing to reduce any stigma. And we are really hoping to promote to other organizations now to adopt these above principles and starting to build their own programs. And again, if I can leave you guys with anything, just helping to promote and maintain those psychologically safe work environments for all employees across all professions and occupations. And I really think that this program and these types of ideas can be carried across and implemented into all professions. And I'm just so happy to be able to have spoken to you guys about this today. So if you've got questions, hopefully I have some answers for you. And if there's any connections, please feel free, let me know.
Rhea, thank you so much. I learned a lot today, and it continues to really reflect that all three of our presenters here are actually talking about similar things. So really looking forward to our group Q&A. So we'll join you, if you could join us, pardon me, after Elizabeth speaks. I'll look forward to seeing you again soon.